Nick Majerison here. Welcome to Top Med Talk. Now, before we get cracking, Top Med Talk is going to be at the International Fluid Academy Day on November the 23rd in Amsterdam. Full details, topmedtalk.com. Click on the section marked Events. You'll be able to find out more. It's on November the 23rd. It's in Amsterdam. It's the International Fluid Academy Day. Going to tell you more about that towards the end of the podcast. In the meantime, it's time for today's Top Med Talk. Preoperative anemia is a risk factor for poor outcomes. It's about standing up a preoperative anemia clinic. It was taken from the EBPOM USA Master's Course, Perioperative Care Practicum, recorded in April in Atlanta of this year. And it features Laurie Heller. Have a listen. This is part 1 of 3.
Top Med Talk.
We're going to begin this morning's discussion with how one and why one should bother to even set up a preoperative anemia clinic. It gives me really great pleasure to introduce our first speaker this morning to you, Dr. Laurie Heller. Currently is a cardiac anesthesiologist at the Heart and Vascular Institute at Swedish Hospital, and she's been there for the better part of a decade, since I think 2003. But Laurie's journey toward her current role at Swedish has been, laudable. She's double-boarded in internal medicine and anesthesia. She did a fellowship at the University of Chicago, I think, with some guy named Sal Aronson a long time ago. God help her. Really, I'm so proud to see how she's really evolved in this space. Laurie established the first preoperative anemia clinic in the country back in 2005. There's been a number of us who have learned a lot from her, who have implemented her actions and successes, and I think she's really probably one of the four thinkers and most skilled experts to teach us about how she did that and why she did that at Swedish Hospital. So with no further ado, I'm going to give the mic over to Laurie. Thank you, Laurie.
Thank you. Thank you for that lovely introduction and for inviting me today. Okay, so this is where I'm from, Swedish Hospital Medical Center, and as of 2012, we have aligned with Providence Center, but one of the very few organizations in the Providence system that was allowed to keep our original name, and that's just because of our standing in the community. But we have 6 hospitals. That's our main campus there with about 600 beds. We have a few surgical residencies, including general surgery and family practice. We have a bunch of fellowships. We have medical students and residents from the University of Washington and from Virginia Mason that come and spend time with us. And we have a standalone cardiac hospital, which is where I spend most of my time, and a standalone orthopedic hospital, as well as 3 other community sites. So I thought I'd start the morning with a case that you might see tomorrow, or not tomorrow, maybe Monday or next week. But this is a 65-year-old gentleman coming in for an elective total hip. He has sort of our usual constellation of comorbidities with diabetes and hypertension, and he gets his normal cardiac workup. All looks good. Stress test is normal. He's a non-smoker, doesn't have any pulmonary disease, and he's on the regular medications for his diabetes and high blood pressure. He gets some pre-op labs, and they look like this. His crit's 33.6. His creatinine is 1.3 with a GFR of 78, and of course he's got that clearance from cardiology. So the question is, do we go ahead and proceed with the case? And we'll come back to this at the end, and hopefully you can realize, though, that with this anemia talk, with this crit of 33, that maybe we shouldn't go ahead, but we'll come back to that. So preoperative evaluation historically is really just those 2 things, with cardiac evaluation and pulmonary evaluation, and we thought that if patients' blood pressure is under control and they don't have a lot of myocardium at risk and their cardiac function is normal and they're non-smoking and they have good pulmonary function, then it's okay to go ahead and proceed with our elective surgery. However, there's been a movement, as you all know, and why we're here today, in recent years now, this Strong for Surgery movement that really ensures that our patients are doing well and are healthy before their elective procedures. I don't know how many of you know, but the Strong for Surgery protocol came out of Washington State with surgeons across the Seattle area, and we're opting for glycemic control and smoking cessation, nutrition and medications, and now anemia management. So how big of a problem is it? Well, it's a big problem. About a third of our patients coming in for surgery, before we've even touched them, are already anemic. And how do you define anemia? That we use the World Health Organization classification for it, with men for crits less than 39 and women's crits less than 36. And there's about a third of our patients coming in are anemic. Out in the community, it's even higher, so about up to 60%, depending on who you look at. So nursing homes or hospitalized patients, about 60% of the patients are already anemic. So then you look at these numbers and you wonder, well, if all these patients are anemic, maybe those aren't the right numbers. Maybe patients should have a crit at 34 or 32, maybe that's normal. But if you look at these numbers and across the board, anemia is not a good thing. We have decreased 5-year survival rates, higher hospitalizations, and they don't do as well. And then when we look at survival across this is a 8-year survival curve. We can look at, these are women who are not anemic, men who are not anemic, and then women who are anemic and men who are anemic. And you can see it's an observation and association, but across 8 years, patients who are anemic don't do as well. And then when we look at our preoperative anemia in the surgical space, we find that they don't do as well either. So this is a retrospective review, 8,000 non-cardiac surgery patients, looking at the prevalence of anemia and how they do. And you can see that, sorry if there's pointing here, on postoperative days, even up to 3 months later, patients who are not anemic do much better than patients who started the day anemic. And the interesting thing about this data now is when we think about anemia, we used to think, well, patients whose crits are 28 or 30 or 32, but these are patients who are anemic with crits less than 36 and 39, anywhere decreased from normal for men and women, and adjusted for other risk factors and for transfusion or severe anemia. So when we're looking at severe anemia, patients whose crits are in the low 20s or mid-20s, they took those out of these trials and found that they still did worse. So if you were anemic, your odds ratio for mortality was twice as high. This is the same study, and just looking at a hematocrit as a continuum, so you can see your hematocrit of 45 going down, and for men and then for women, and as your hematocrit goes down, your increase for mortality goes down. And this also looked at your risk for transfusion, but again, a lot of these studies will show that transfusion is an independent risk factor along for that. This is a veteran study, so mostly looking at men, but an elective study showing as your hematocrits come down from normal of 39, your 30-day mortality rate, your 30-day cardiac event rate, and these are patients for non-cardiac surgery, crits less than 39, they did much worse. So a 1% increase in 30-day post-op mortality associated with every percentage point decrease. So every number going down from a crit from normal, you had a higher risk of mortality. This is just looking at other risk factors associated with anemia. So these are patients with different, maybe you can see this on the lower slide, but these are different subsets and comorbidities. So cardiac disease, COPD, renal disease, cancer. And when they have anemic and not these different situations, they have the higher risk of mortality. But when you add anemia on top of that, they do even worse in this perioperative setting. This is a study, this is from that NSQIP database. You guys familiar with the NSQIP database? It's a surgical database from the American College of Surgeons, and it's a nationally validated and risk-associated outcome-based information where a lot of private practice hospitals and academic centers send all their information to this, and they analyze it in a very robust way and give us a lot of interesting and useful data. This is looking at spine surgery outcomes, 24,000 patients for elective spines, and showing that even with moderate anemia, you have a much higher length of stay, postoperative complications, any complications, and 30-day mortality. And then we can look at different subsets of patients. This is looking at preoperative anemia and cardiac surgery outcomes. You can see many observational data, but again showing increased mortality, increased neurologic effects, renal insufficiency, and postoperative delirium. So, we know that anemia is bad. I think we've proven that. And therefore, we would think that transfusion must be good. And that's been the old way of thinking and the way of thinking for a long time. However, we know that that's the old way of thinking, and that's not the answer. So, anyone know how long we've been doing transfusions? How long has transfusion medicine been in existence? So civilian transfusions have been around since the 1940s. So we had our first blood bank established, first civilian blood bank in 1949. And it's interesting to note that we didn't actually start regulating transfusion until 1974. So the FDA got involved in the 1970s, so a good 30 years later before we even started regulating it. There actually were no prospective randomized controlled trials about transfusion until 1999. And that, of course, we've seen these slides before, but the big study that was done was by Ibert, the TRIC trial. You guys are probably all familiar with this. But this was a young Canadian researcher, and he decided that he wanted to prove once and for all that the hematocrit that patients needed to have in the ICU was 30. He said, I knew it, I felt it, it had to be 30, and he wanted to design a study to show that. And so he randomized the folks to 2 transfusion takers. He took patients on 25 ICUs across Canada, all comers, so they were, heart failure, post-op hearts, post-op surgery, pneumonia, multi-system organ failure, whatever they had, and stabilized them for the first 24 hours, and then randomized them to two transfusion triggers. The restrictive group and the liberal group. So they waited, in the restrictive group, they waited until their hematocrits were 21, and in the liberal group, they waited until their hematocrits were 30, and then decided to transfuse them. And what they found was very surprising. It was shocking to him and shocking to the rest of us, but what they found was the overall 30-day mortality was similar. There was a trend towards the restrictive strategy of transfusion over the liberal strategy, but overall, the p-value was not significant. But when they looked at different subsets of patients, they found that certain patients did better. So patients who were less sick, so patients still in the ICU but less sick, Apache 2 scores less than 20, they had about half the mortality if they were in that restrictive method of transfusion versus the liberal. Younger patients, half the mortality. And then cardiac disease, those patients that we think really need those higher hematocrits, we definitely need a crit of 30, they did the same. And the mortality rate for the overall hospitalization was lower in the restrictive group. So this was surprising to everyone, and then the rest of the study started launching, looking at this and doing this in a very controlled manner. And so these are just looking at liberal or restrictive transfusion in high-risk patients after hip surgery. This was in 2011 in the New England Journal of Medicine, 2,000 patients, and they randomized them again. These are patients with cardiac disease or risk factors for cardiac disease. Again, randomized them. They had a bit of a different restrictive level. It was crit of 24 versus a crit of 30. And they looked at death and inability to walk unassisted across the room at 60 days, which I think for an orthopedic surgeon is kind of like death, so that's why they chose that endpoint. And they looked at it, and they actually found it was the same. So versus a liberal versus a restrictive method of transfusion was exactly the same, and similar rates of complications. So this is an article, and I love this. I love reading the surgical literature because they kind of tell you everything you need to know. You know, when you look at an anesthesia journal, it'll say sevoflurane and postoperative nausea and vomiting, and you have to read the article. But in general surgery literature, you just have to read the title. So intraoperative transfusion of 1 to 2 units of packed red blood cells is associated with increased 30-day mortality, surgical site infection, pneumonia, and sepsis in general surgery patients. So we're done. We don't even have to talk about it. But But here it is. So here is the NSQIP database, and again, that NSQIP database from the American College of Surgeons, 125,000 patients looking at transfusion and 30-day mortality. And they found that a single unit of transfusion in these patients increased the risk for 30-day mortality, pneumonia, and sepsis and shock. If you gave them 2 units of red cells, they had all those risks, plus surgical site infection. And here's that graph here showing that. So and this was adjusted for 30 patient risk factors. So diabetes, whether on beta blockers, calcium channel blockers, how much blood they lost during the surgery, transfusion, all this independently associated with transfusion and mortality. And then there's more. So if you look at transfusion and long-term survival, so it's not just in this perioperative period, but these are first-time CABG patients 5 years out. If they had no transfusion versus transfusion, survival rate much lower if they've had a transfusion. This is survival rate 5 years out, no transfusion, intra-op transfusion, post-op, and both. So adjusting for co-founding factors, transfusion was still associated with a 70% increase in mortality. This, again, NSQIP database, but looking at surgical site infection, and they took 117 private practice hospitals, like Swedish, and they looked at the surgical site infections hospitals that had high outliers, so lots of post-op infections, versus low outliers, so very little post-op infections. And they found that patients who were anemic or patients who were transfused, those hospitals had higher risk of post-op infection. This is a meta-analysis, again, just looking at, all developed similarly to the Iber study, to the TRIC trial, and our relative risk ratio, and you can see all these boxes fall over here, favoring restrictive methods of transfusion. So again, transfusion does not improve our outcome. So why is that? What's going on? We are giving patients are anemic, they have low crits, they have low oxygen delivery. We're giving them methods to give them oxygen delivery by red cells, right? Well, it turns out that's not actually the case. So when we're giving them these transfusions, as allogeneic transfusions, we're giving them blood that's been in the refrigerator for 40 days. That's very different than the blood that's in your body stored at normal temperature. Okay, so this is an electron microscopy of a red cell, an erythrocyte, and you can see that the shape and the size is actually very important. The size of a red cell is about 8 microns, and capillary is about 5 to 10 microns. So those red cells have to squish and deform, and they have to be able to get through from the arterial side to the venous side. And when they're stored in the refrigerator, things happen to those cells. So they become stiff, they become unable to get through those capillary systems, the cells begin to lyse, they become spiculated, and you can see they look very different at day 21 versus day 35 when they're actually starting to congregate together. The other thing that happens in that unit of blood is these cytokines start to develop. And so the cytokines, the interleukins, the things that really make you feel terrible when you get a cold or when you have cancer, those things start to build up by day 40. So this is just a cytoscan, so showing some microscopy about blood going through your body, through the arteries and the veins and the capillaries. And I hope you can get the idea that things are moving on briskly, nicely. And this is what happens after a 2-unit transfusion. So it's very different, right? Yeah, so you can see when we're thinking about giving our red cells and we're thinking about we're increasing oxygen delivery, we're actually not really doing that. Okay, so we know that presurgical anemia alone is associated with increased morbidity and mortality. We know that presurgical anemia is actually the strongest predictor of need for blood transfusion. It's not what your surgery is, it's not who the surgeon is, it's actually what your starting hematocrit is. And we also know that blood transfusion is associated with an increased morbidity and mortality in a dose-dependent manner. So what do we do? Well, the answer is that we treat and diagnose and treat preoperative anemia.
Top Med Talk.
This is taken from the hugely successful EdPom USA Masters course, Perioperative Care Practicum, which took place in Atlanta earlier this year. I mentioned at the beginning of the podcast we're going to be covering the International Fluid Academy Day on November the 23rd in Amsterdam. Now, this is a great opportunity for you to meet the team if you want to come along. All you need to do is check out the website, topmedtalk.com, click through to events, and you'll find a full piece on the website detailing everything you need to know about the International Fluid Academy Day, November the 23rd. Now, we've set up a Slido account for people who want to interact with us and our guests during the International Fluid Academy Day. Here's how you get to that. Go to slido.com. I've got a login for you. It's hashtag TMT IFAD18. So IFAD, International Fluid Day 18, and TMT, of course, standing for Top Med Talk. So that password, once again, slido.com, hashtag TMT IFAD18. So TMT IFAD 18 is an easy way of remembering that. You can get onto there, put your question in early, and have a chance of having it answered sooner rather than later. Don't forget that login, TMT IFAD 18. That's hashtag TMT IFAD 18, and that's on slido.com. And then, of course, if you think you can come along to the day itself, that'd be great. We'd love to see you. Amsterdam, November the 23rd. Go to the website, topmedtalk.com, and click on the section marked Events. Also, of course, you can download our full back catalogue at the moment here on Top Med Talk. All you need to do is go to your podcatcher and click Download All, or scroll through them individually and clicking Download on each one, or go to the website, topmedtalk.com, and explore our back catalogue, downloading as many as you can. It's entirely free. You can get all of the back catalogue at the moment. We're currently sorting through it, so it may not always be available in that form. So get yourself to the website, topmedtalk.com, and download all of our podcasts, our entire archive, whole back catalogue, many, many hundreds of valuable podcasts with incredible information within.